So firstly, thank you very much to the Society and to Maya in particular for arranging this session. And I'm going to talk you through what it's really like, and I've chosen the title of, as it says, The Good, the Bad and the Ugly. So firstly, I have no conflicts of interest, except I actually do. So my first slide is my alternative disclosures. So first of all, I'm an ST5 and I'm an ACF, which means I'm on both an academic and a clinical training pathway. And that means that I'm training now. So that's something to tell you. I also thought that I should probably tell you quite early on that I actually chose endocrinology when I was a third-year medical student. So that's actually a really long time ago. But I did make sure that I went and tested other specialties on that pathway from then till now. And I think that's really important. And I always found myself either coming back to the medical aspects within all the other specialties that I went to, or even within that, really coming back to the endocrinology. I suggested the topic for this talk to the programme committee, so I thought I should probably disclose that to you too. And it's been a long-term passion of mine, really, to think about really inspiring the next generation. As a percentage, as many undifferentiated trainees come to these meetings as some of the consultants. So it's important that we can access you and tell you how awesome the specialty is. So one of the reasons why I wanted to do that was also because my previous experience of careers talk. So on the basis of that, I promise that I will not show you any training pathway diagrams. I won't show you any pictures of any offspring that are any close to me, or talk of times that are really so far gone that they're just not relevant to us anymore, or slag off any other specialty in order to make endocrinology look any better. So with that in mind, let's talk about the good, which is endocrinology. And in order to do that, we need to go back to the patients. So this is a lady, one of them who I saw when I was a medical student years ago, who was told that she was just fat and she needed a walking stick because she was getting old. And actually, of course, she had Cushing's. And with the right treatment and the right diagnosis, you can make this woman look like she used to again. And that's pretty cool. And you can also change her long-term outcomes. So her outcomes for bone health, for psychological well-being, and all the other metabolic effects that you know. You can also find people languishing around on takes. So someone's called it ACS, because that's what they always call it, because common things are common, right? But actually, sometimes they're not, and sometimes it's a pheochromocytoma that someone thinks is a good idea to stick a needle in it, and you have to call someone and say, please don't do that until I've come to see the patient. And again, with the right diagnosis, the right history, you can make the right diagnosis and change a patient's outcome who's sitting in front of you. This was another patient who I met a long time ago on that block at King's, who'd had multiple presentations with kind of collapses, feeling unwell, no one really getting to the bottom of it, until he had a car crash. And someone at the scene thought it was a good idea to do a blood sugar, and it was low. We then diagnosed his insulinoma, he had surgery, he never had another problem again. Again, pretty cool. And then again, the complex of endocrinology, so a nasty craniopharyngioma in someone who's had multiple surgeries, who's now got hypothalamic syndrome, who therefore can't remember that he needs to drink. He doesn't even sense thirst anyway. How do you manage these people? Well, what we did is we weighed him every day and we took his sodium every day. We made a curve, and then his dad would weigh him every day and tell him that that was how much water he had to drink. I mean, that's awesome. So why is endocrinology good? Well, it's the complexity that we've already spoken about today and that you would have seen, and it's also the variety, but it's the variety on a theme. So it's not like A&E where you will see old person, child, trauma, but it's varied within a context. It's multi-system diseases, it's not just single organ problems. And it's also one of the last remaining specialties, I think, that is actually still history examination and data interpretation. Endocrinology can't really be protocolized in the same way that some of the other medical specialties can. It's also detective work. There's numerous subspecialties, so if you've got a subspecialist interest, there's a home for you in endocrinology. It's both acute presentations and long-term follow-up. And with the right diagnosis and the right treatment, you could see the improvement in front of your eyes. So if someone's has undiagnosed Addison's disease and you give them hydrocortisone, you will see them get better in front of you. And then you've also got their long-term outcomes that you can improve. You work as part of an MDT, and it's mostly an outpatient specialty, which some people like. So what's the bad? Oh, it's that diabetes thing that everyone talks about. And it's all about diabetes foot. But actually it's not. And even if it is, then that's really important. There are people our age who have already had type 1 diabetes for 20 years, who have foot problems, eye problems, kidney problems. It's actually really important. And a higher percentage of them will die in the next 5 years than some cancers. So yeah, they can smell, but actually it's not that bad. And it's also the ability to impact on other subspecialties within diabetes. So allowing and enabling a woman to have a normal, healthy baby rather than a macrosomic, unhealthy baby. And also the ability to work with emerging technology, so insulin pumps and all the other stuff. So is it really the bad? Well, no. It's not just diabetic feet, and actually that's important. There's a huge burden of disease to the patient. So anyone who's on insulin has to, every time they leave their house, have I got my insulin, have I got my checker, have I got my short-acting hyposnacks, long-acting hyposnacks? We take for granted just leaving with our keys, wallet, and phone. It's also a huge burden to society. It's really an expanding field, so community placements, hospital placements for inpatient diabetes. It's, again, acute presentations versus long-term follow-up. There's rapidly progressing technology, both in terms of insulin pumps, closed-loop systems, but also new therapies such as the DPP-4 inhibitors, GLP-1 agonists. Even just the checkers are better than peeing on sticks and waiting for them to go blue, like a lot of our patients had to do not that long ago. There's numerous subspecialties. Is MDT working again? So what's the ugly? Oh, it's that GIM. Keep calm and bleep the medical reg. It's true, they really do. And I wish I'd kept a list of all the things that random people have called me about when I'm on call. And this is what puts a lot of people off the specialty. But again, is it really that bad? You're seeing many, if not all, of the sickest patients in the hospital. And they need your help and they need your expertise. You're supporting your team, and also you're supporting juniors from other specialties who may have worked with you when you were on medicine who are struggling to look after that patient. Many of your colleagues won't do it. Someone's got to do it. So we're actually best placed because we're one of the last remaining generalists. As a consultant, you'll be doing less frequent on-calls than you are now as an SHO or registrar, and you'll also be invariably rostered onto covering the wards. And hopefully in the future, many other medical specialties who have left the rota should be coming back, and therefore we'll be doing less frequent GIM on calls for less time in one day, and that will be better. There's opportunity for research as well. So I delayed my start to registrar training for a sabbatical in adrenocortical cancer, and the reason why I did that was because a case at King's. So a 28-year-old female with 5 months of abdo pain, early satiety, and nausea. She had an ultrasound which showed a large left abdominal mass with liver mets. She had grossly elevated urine and serum steroid precursors, and a staging CT which showed adrenocortical carcinoma with extensive metastatic disease. She went on to have surgery. She had awful histology with anaplastic features, rapidly progressive disease, and despite a cycle of standard chemotherapy for ACC, she died 6 weeks later. We have to do better. So I went to Sydney, and I worked in the colling, and this is some of the results. So this are both adrenal cancer cells. One is treated with vehicle, ever getting bigger, and one is treated with a potential new therapeutic drug, holding that proliferation. And also we were able to show that we could change the hormone profile of those tumour cells as well. So tips, tricks, and the magic of hindsight. It's a great specialty. You shouldn't be put off by GIM or diabetic feet. It's not bad, it's not ugly, most of the time. Experience endocrine clinics, preferably in a tertiary centre if possible. You'll be surprised how much endocrinology there is in the district generals if you go looking for it. But it's nice to spend some time in a tertiary centre. You can get off the treadmill and you can make a slightly different training path with help from yourself and with the right people around you. A good mentor is invaluable. You need to try and develop long-lasting collaborations, and these can be international if possible. Engage with the society and all it has to offer. There's so many opportunities for student membership and for trainees membership, much, much more than when I first was introduced to the society. So make use of those opportunities. And at this meeting, try and go to the Meet the Expert sessions, the plenaries, the oral communication sessions. You'll get much more out of them than if you try and go to some of the higher level sessions, which you may find are just way over your head. This is what you're doing on the wards. And don't attend a conference without also presenting something, because it's not financially sensible. So just to quickly acknowledge, the patients, that's why you do endo. My first mentor, my clinical mentor, Dr. Elwyn at King's, my mentor in Australia, Rory Clifton-Bly, and my current mentor now in academia, which is Warjit Dillo. To Maya, thank you so much for putting the session on. And these were the pictures that I've included in the talk.
Great, thank you very much for that. Are there any questions for Julia, who's a current trainee, as you heard, who wants to know about? I'm hearing that a lot of this is going to be about the wide variety and different options that both John and you've mentioned. There's diabetes and endocrinology, and in fact, eventually, where you go is very unpredictable in some ways. Would you agree with that, John?
No, definitely agree with that, yeah. But I think, and also you have to embrace the fact that you may have to move around, because that will be potentially to your advantage.
Any other questions from anybody? Everyone daren't ask anything, but do feel free to just put your hand up and say what you want to.
Or I'll be at the quiz or here until Wednesday, so if you do want to ask in front of everyone, you can ask then.
Okay, maybe we should hear a bit.
Go
Oh,
on.
yes, go.
Yeah. Okay. So showing your commitment to the specialty. So you're here, that's a good start. Hopefully you're a member of the society. If not, it's free for undifferentiated trainees, so you should become a member. Things like MRCP that I'm sure you would have had already. And try and make it, if you imagine that you're the person reading it, so make it as easy for you to process it as if you were that person. So if you can highlight and signpost, and I actually did mine in bullet points, which some people won't agree with and will tell you not to, but I just thought, it's easier. And also then all that white text box writing that's really awkward to write, you don't have to write anymore because it's bullet points. And, again, people think that it's really important to come and present, like, the best piece of research ever. Like, it's not. If you've done a case and you've had a poster and you've presented it, then that's a presentation at a national conference. That A, shows commitment, and B, shows that you've got something about you. So interview, practice with as many people as possible of different people. Make sure you read the personal specification. Make sure you know what the stations are going to be. Be confident on the day, all the standard things that you would say for any interview, but we can talk about it in more detail afterwards. Yeah.
Variety really appealing within the specialty, but as you go further up, is there pressure to sub-specialise?
So it depends if you're working in a district general or a tertiary centre for a start. So, and now sometimes even in community. So if you're working in a DGH, then you may well do some endocrinology and diabetes, but it's likely that you will have one area that's your kind of lead for in that department. And that also works with what the other specialisms and interests are of the other consultants who you work with. If you're in a tertiary centre, then you're more likely to be subspecialised. But it's still... The beauty of endocrinology is that it's still variety within that subspecialty. So you'll still do an endocrine clinic where all of endocrinology comes to your clinic. So you may be someone who only does endocrinology and not diabetes. And if you're super, super specialized, then you probably do need to do that because you can't, keep up with everything. But there's still variety within either then endocrinology or diabetes to...
I think it's worth saying that you have a choice in all the decisions that make. So although I don't think it's pressure to specialise, I mean, you can choose to become more interested in an area. And John was saying that the job he does now is different from his consultant job that he was appointed to. I mean, the same applies to me. The job I applied for was 80% with rats, and now I do mostly human work. Yeah. So, you know, it's and that was as a consultant.
Yeah. So it's a bit like I said, you know, also you can make your own path for yourself a little bit. So obviously if you're employed to do X, you can't turn up and go, no, actually I want to do Y. But, you know, with business cases or expanding services that aren't there already that you've spoken about at interview, or there's someone else in the department that says, I really love antenatal care, and I would say, that's great, it's not my area of interest, why don't I do this and you do that? It's about working together.
Any other questions from anybody about? Okay, thank you.